Well, thanks for the invitation, Asim, and for the introduction. I think just before I jump into this talk, I should mention a couple of disclosures, mainly some grant support and consulting fees from both Baxter and Medtronic are probably the most pertinent to this talk. So I was asked to talk about sort of ventilation issues with COVID-19 positive surgical patients, and I saw Brian was talking about the anesthesia issues before this, so I decided to focus on more how do we approach a COVID-19 post-op surgical patient. So we've operated on the patient and they've developed essentially a post-op pneumonia from COVID-19, because that's how this is going to present. And when we're really talking about COVID-19, we're talking in the hospitalized patients, we're talking about managing a difficult pneumonia. So Jyoti already covered some of this, and really for most of the patients, the good news is about 80% are probably not going to give us too much trouble. They're only going to experience a mild or moderate pneumonia. So that means this is data from the WHO trip to China, and what they noticed was about of this 80%, about half didn't really even have chest x-ray changes, just a very, very mild pneumonia. And I think the ones we're worried about and the ones where we see the complications and the death are really the remaining 15 to 20%. And these are the patients that become hypoxic, they need a lot more support and potentially go on to get critically ill and end up in the ICU on a ventilator. So I just thought I'd focus on the issues that are particularly different about these patients in our experience over the last 3 months. So any pneumonia, I mean, obviously the main thing we worry about is the hypoxia. And for COVID-19 patients, it's no different, except the hypoxia tends to be worse in those severe patients. The way we approach hypoxia in a COVID-19 patient is really no different. You start with supplemental oxygen, and if that's not enough, you escalate your care. And what I thought I'd focus on is when we get into the range of ventilatory support and the issues related to these. So I think any intensivist, when we first started hearing about what we now call COVID-19 and the situation in Wuhan, the first things we were all worrying about and the things we were all talking about is normally when we have a patient with pneumonia who ends up in the ICU or ends up approaching the ICU, a lot of the time in the last 10 or 15 years, we manage these with high flow oxygen therapy, high flow nasal cannula, or some centers NIV. But of course, these interventions, you can imagine, particularly with high flow oxygen, but also NIV. NIV, you get a lot of leak from the mask. With high flow oxygen, you're delivering anywhere from 21 to 100% oxygen through the nose at a flow rate of 60 liters per minute. And we're talking about a highly infectious respiratory tract infection. The question everybody has is, do these interventions increase the risk of nosocomial spread? To help us with this, there's been essentially 2 guidelines released in the last 3 months. The WHO provided some clinical management guidelines, and also the Surviving Sepsis campaign provides some guidelines. And what they tell us is we should probably be choosing high flow oxygen therapy or high flow nasal cannula over NIV in these patients if they've got hypoxemic respiratory failure. And both guidelines initially said that the risk of environmental contamination with these interventions was no higher or similar to the risks with conventional oxygen therapy. And I just thought I'd spend a few minutes unpacking these 2 statements. So first of all, why do we recommend high flow oxygen therapy over NIV in these patients. And this is now a recommendation that's pretty ingrained in intensive care practice. And for the last 5 years, we've based these recommendations predominantly on this study from, it was a French study. They randomized over 300 patients into NIV, standard oxygen, or high flow. Now, these were patients with hypoxemic respiratory failure, but the majority, well over 80%, actually had pneumonia. And you can see from their survival curves that the clear winner is high flow oxygen therapy. And of course, related to this, the patients that were more hypoxic, the PF ratio less than 200, high flow oxygen therapy compared to the other two interventions seemed to keep people off the ventilators, which again is a desirable outcome with any hypoxemic respiratory failure or pneumonia. So why is NIV less effective compared to high flow oxygen therapy? Or why is it associated with an increased mortality? Well, it seems to be because for whatever reason, we end up delaying intubation when patients are on NIV. So we know from the NIV data is if we're treating any pneumonia patient, viral or bacterial, with NIV, if you keep them off the ventilator, it's great. They have a very low mortality. In fact, most studies close to 0. But the problem is if these patients end up going on to need intubation after being on NIV, we're seeing mortality rates in the range of 50%. And this is a lot higher than the conventional mortality we see for intubated pneumonia patients, which is closer to 20%. And this next slide probably shows us why that is. And what we see is that the patients that die on NIV, they're getting intubated later. And we think this delay in intubation is what's contributing to the mortality. For some reason, we don't see that with high flow oxygen therapy. And I don't know why that is. It might just be that because we're getting a little bit more ventilatory support with NIV, we're feeling overly reassured and leaving it on longer. And I just wanted to unpack this statement too. To say that high flow oxygen therapy has similar environmental contamination rate to conventional oxygen. They also said similar statements about NIV in both guidelines. And they're basing this on 3 studies. And I've just shown one of the studies here. The studies were based in essentially simulation patients. And the WHO were actually challenged from multiple angles on their statement in January, and have since revised their statement and have removed their statement about high flow oxygen therapy being as safe as conventional oxygen. And I think it was appropriate to do that. And the reason for that is because the data they were basing their recommendations on, and it's the same for the Surviving Sepsis campaign, were these lab-based studies in patient simulators. So these aren't real patients. And what they're essentially showing is that with high flow oxygen therapy, if your cannulas fit well and your patient has lung injury, you don't get a lot of aerosolization of the respiratory tract secretions. A bit more with normal lungs because they have a higher tidal volume. But the problems with this is a simulation. So the patient's not moving, the patient's not coughing. And in my experience, patients with pneumonia, they're moving around the room, they're coughing, and the nasal cannula are always slipping out. It's not a tight, snug fit. So to extrapolate this to the clinical situation is risky. And on top of that, we have some of the data, I think Jyoti showed some of this work. We can detect viral RNA in the air room of our patients. And Not only that, and this, I think Jyoti also showed this, this is just comparing aerosolization and virus survival with the SARS virus and now our COVID-19 virus. You can see that the virus does survive aerosolization. So we have to be extremely careful with any interventions that cause aerosolization. And so I think it was appropriate that WHO revised their recommendations, and the Surviving Sepsis campaign haven't yet, but there's talk that they may. So really, when we approach these pneumonia patients, we can use NIV or high flow oxygen therapy. The recommendation is no different to any other pneumonia. We should be using high flow over NIV, but you've got to use it with the airborne precautions. Because if the patient progresses on to require ventilation, and because of the airborne precautions and anxiety in the staff, we are tending to jump from supplemental oxygen to intubation in our patients. We're not using much high flow or NIV. Once they're on the ventilator, how do we approach it? Well, different to conventional pneumonia, right from the outset, once we intubate these patients, it's very clear we're dealing with ARDS immediately. The way we ventilate these patients is no different to any other ARDS patient. We try and match the ventilator to the physiology. We use as low a tidal volume as possible, starting at 6 mils per kg ideal body weight. We try and keep the plateau pressure below 30. If it's above 30, we go down on our tidal volumes. And we try and keep the FiO2 as low as possible. In our ICU, we tend to target SATs of 88 or above. We titrate the PEEP. One of the differences, which I'll come on to in a minute, is we have to be really careful with the PEEP in these patients. And we're tending not to follow the standard ARDSNet PEEP tables, but we're trying to match the PEEP to the patient's physiology. Normally, when I'm dealing with a post-op pneumonia and I'm putting them on the ventilator, these patients are also septic and I'm giving them fluid. And they'll end up on the ventilator for a day or two. We'll be able to wean them and we're all happy. And because I'm giving fluids, I'm good friends with my surgical colleagues because these are post-op patients and we like to give them fluid. But because I think one of the differences you're going to see when these patients go on the ventilator is because they're essentially in ARDS once they're on the ventilator, is we tend to practice a bit more of a restrictive fluid strategy. That doesn't mean we don't give fluid, but it means we want to make sure we're truly helping the patient before we give the fluid. And that might cause us to fall out a little bit with each other once the patient's on the ventilator. But what's really interesting and starting to emerge in the literature, what we're seeing in our ICU and from colleagues across Singapore, they're also seeing the same. This is not typical ARDS. And the reason it's not typical ARDS is because we're not seeing a lot of lung collapse and we're not seeing the poor lung compliance that we normally see when patients get this hypoxic. And it's just some data from the first 10 ICU patients. Once they're on the ventilator, these plateau pressures for ARDS patients with PF ratios around 100, these are pretty good plateau pressures. Normally we'd be struggling to keep our plateau pressure below 30, which just reflects that the compliance is not as bad in these patients as it normally is for ARDS. And that's why we have to be so careful with the PEEP, because if the compliance is preserved, higher PEEPs is not really going to help the patient. And in fact, could be harmful if we start chasing the arterial oxygen with our PEEP too much. And this is just a letter that was recently published by the Italians. They noticed the exact same thing. This is compliance of some of their patients. This is not normal. So normal ARDS patients will have compliances in the 20 to 30 range. 50 compliance of around 50 is actually not that horrible. This is pretty close to normal. And it's not just the Italians, the Chinese have reported this too. And in this study, one of the interesting things and one of the important things why we need to be aware of this with our COVID-19 patients is that when compliance is reserved, our lung doesn't need recruiting. So we don't need the PEEP. Recruitment maneuvers and even proning sometimes may not help these patients. So we have to be extremely careful. The key thing, particularly with the cardiac issues starting to crop up, is we don't want to be giving these patients too much PEEP. So I think just in summary, for most of these patients, if they develop a post-op COVID-19 pneumonia, the majority will hopefully get by just with a little bit of oxygen. If you're gonna have to escalate support, high flow oxygen therapy is preferable to NIV, but again, you've got to be very careful about taking the appropriate airborne precautions. And once they're on the ventilator, we're going to be treating these as ARDS from day one, because that's the way they behave, but it's not normal ARDS, and we're having to be a lot more careful and a lot more physiologic about how we choose the PEEP for these patients. That was my last slide, I think.